Hello everyone and welcome to this new lecture. Today we will talk about the gingivitis and periodontal diseases in children. The periodontium is made of the gingiva, periodontal ligament, cementum of the tooth, and also the alveolar bone. The gingiva is the part of the oral mucosa that's keratinized and is covered or is covering the alveolar bone process and teeth. The gingival tissue are usually light pink in color, but color may be varying from in relation to complexion of the person. So the person's skin color can change in different people. Thickness of the gingiva also different, and the degree of keratinization between people is different. The surface of the gingiva of children appears less stippled or smoother than those of an adult. In a healthy adult, the marginal gingiva has a sharp knife-like edges. This is within the marginal gingiva. During the period of tooth eruption, the child, however, the gingiva are thicker and have rounded margins due to the migration and cervical constriction of the primary teeth. Now let's talk about the gingivitis. What is a gingivitis? An inflammatory involving, or it's an inflammation involving only the gingival tissue next to the tooth. Microscopically, it's characterized by the presence of inflammatory exudate and edema. Some destruction of the collagenous gingival fibers is also present, and ulceration and proliferation of the epithelium facing the tooth and attaching the gingiva to it. So we have proliferation, edema, exudate, destruction of collagenous tissue, redness, etc. of the gingiva. Marginal gingivitis is the most common form of periodontal disease and starts in early childhood. Again, what is the most common form of periodontal disease? The answer is marginal gingivitis, and marginal gingivitis starts in early childhood. Severe gingivitis is relatively uncommon in children, although numerous surveys have shown that a large portion of the pediatric population has a mild, reversible type of gingivitis. The major etiology factors associated with gingivitis and more significant periodontal disease are uncalcified and calcified bacterial plaque. However, gingivitis rarely progresses to periodontitis in preschool children because of the immunologic and microbiologic factors as compared to adults. So here it is saying that the major etiological factor associated with gingivitis and periodontal disease are uncalcified and calcified bacterial plaque. As usual, plaque is a major contribution to gingivitis. Simple gingivitis is divided into eruption gingivitis, gingivitis associated with poor oral hygiene, and allergic gingival inflammation. Acute gingivitis also have many divisions: herpes simplex virus infection, recurrent aphthous ulcer, acute necrotizing ulcerative gingivitis, Veneset disease or acute candidiasis, acute bacterial infection, and then we would have a different classification, that is gingival diseases modified by systemic factors. This will be gingival disease associated with the endocrine system and with genetic origin, like heredity gingival fibromatosis. Then we will be talking about the Phenotoid-Induced gingival overgrowth and ascorbic acid deficiency Gingivas. But first, let's start with simple gingivitis. Simple gingivitis include eruption gingivitis. That's a temporary type of gingivitis often observed in young children when the primary teeth are erupting. This gingivitis, often associated with difficult eruption, subsides after the teeth emerge into the oral cavity, and the greatest increase in the incidence of gingivitis in children is often seen between the age of 6 to 7 years, when the permanent teeth begin to erupt. This increase in gingivitis apparently occurs because the gingival margin receives no protection from the coronal contour of the tooth during the early stage of active eruption, and the continual impingement of food on the gingiva causes the inflammatory process. Food debris, materia alba, and bacterial plaque often collect around and beneath the pre-gingival tissue, partially covering the crown of the erupting tooth, and cause the development development of inflammatory process. The inflammation is most commonly associated with the eruption of the first and second permanent molars, and the condition can be painful and can develop into a pericornitis or pericoronal abscess. To be exact and to give you an idea, people with the age group between 6 and 7 are the most affected with eruption gingivitis because the primary first and second molar are the most involved teeth in eruption gingivitis. Treatment: mild eruption gingivitis require no treatment other than improved oral hygiene. Painful pericornitis may be helped often when the area is irrigated with a counter-irritant such as chlorhexidine, H2O2, 6%, and anti-inflammatory drug therapy. Moving on to the gingivitis associated with poor oral hygiene is another type of simple gingivitis. It's usually classified as early, slight, moderate, or advanced. Early gingivitis is quickly reversible and can be treated with good oral prophylactic treatment and instruction in good toothbrush and flossing techniques. To keep the teeth free of bacterial plaque, gingivitis is generally less severe in children than in adults with similar plaque levels. So in children, we have less severe gingivitis associated with bad oral hygiene, even with a similar plaque index. And to treat that, the child have to be instructed to use good oral hygiene methods like toothbrushing and flossing to reduce that gingival plaque. Next, of simple gingivitis, we will talk about allergic gingival inflammation. Gingival inflammatory reactions are enhanced in the allergic children during the pollen seasons. Patients with complex allergies who have symptoms for long period may be at risk of more significant adverse periodontal changes. So these people that are having allergies to pollen or with a longer period symptom allergies will be at an increased risk for more significant adverse periodontal change. Treatment for those patients, allergic patients, include antihistaminic drug therapy, improved oral hygiene, and anti-inflammatory drug therapy. Precaution include keeping away the child from non-allergic type. This is to be used as precaution, but drugs that are used to treat these kinds of patients are antihistaminic and anti-inflammatory. Let's talk about some of the most important acute gingival diseases, one of which is called herpes simplex virus infection. Herpes simplex causes one of the most widespread viral infections. The primary infection usually occurs in a child under the 6 years of age who has had no contact with the type 1 herpes simplex virus HSV1 and who therefore has no neutralizing antibodies. It is believed that 99% of the patients of the all primary infections are of the subclinical type. These subclinical types are goes without notice. The infection may also occur in susceptible adults who have not had a primary infection before. In some preschool children, the primary infection may be characterized by 1 or 2 mild sores on the oral mucous membrane. Again, we are talking about the primary herpes simplex virus type 1. These 1 or 2 mild sores on the oral mucous membrane may be of little concern of the child and may go unnoticed by the patients. Other children, the primary infection may be manifested by acute symptoms. Acute herpetic gingivostomatitis. The active symptoms of the acute disease can occur in children with clean mouths and healthy oral tissues. In fact, these children seem to be as susceptible as those with poor oral hygiene. The symptoms of the disease develop suddenly and include, in addition to the fiery red gingival tissues, malaise, irritability, headache, pain associated with the intake of food and liquids of acid content, characteristic oral finding in the acute acute primary disease is the presence of yellow or white liquid-filled vesicles. Again, the symptoms of this disease develop suddenly and include, in addition to fiery gingival tissue, malaise, irritability, etc. And this is associated with the intake of food that contains acid contact. Characteristic oral finding is how to distinguish the primary infective stomatitis or primary herpetic simplex virus HSV1 from other diseases is the characteristic of the yellow or white liquid-filled vesicles. In few days, the vesicles rupture and form painful ulcers 1 to 3 millimeter in diameter, which are covered with a whitish gray membrane and have a circumscribed area of inflammation. The ulcers may be observed on any area of the mucous membrane, including the buccal mucosa, tongue, lips, and heart, and soft palate, and the tonsillar area as well. In order to treat the herpes simplex virus, HSV1, we would have to, and not only to treat HSV1, also treat the herpetic or the acute herpetic gingival stomatitis in children, herpetic acute gingival stomatitis, which runs a course of 10 to 14 days, should include specific antiviral medications as well as provision of the relief of the acute symptoms of that fluid and nutritional intake can be managed. Again, to treat herpetic gingival stomatitis, acute herpetic gingival stomatitis in children, which runs a course of 10 to 14 days, the treatment should include specific antiviral medications as well as provision for the relief of the acute symptoms so that fluid and nutritional intake can be maintained. The application of a mild topical anesthetic before mealtime will temporarily relieve the pain and allow the child to take in soft food. Because fruit juices are usually irritant to the ulcerated area, ingestion of a vitamin supplement during the course of the disease is indicated instead of these fruits. Number 2 of acute gingival diseases. First, we have talked about the herpes simplex or acute herpes simplex virus HSV1 or acute herpetic gingival stomatitis. Now we will talk about the recurrent aphthous ulcer or canker sore, RAU, recurrent aphthous ulcer, RAS, recurrent aphthous stomatitis, or CS, canker sore. The recurrent aphthous ulcer is a painful ulceration in the attached mucosal membrane that occurs in school-aged children and adults. The peak age for recurrent aphthous ulcer is between 10 and 19 years of age. It has been reported to be the most common mucosal disorder in people of all ages. Common mucosal disorder in people of all ages and races in the world. This disorder, according to definitions adopted in the epidemiological literature, is characterized by the recurrent ulcerations of the mucous membrane of the mouth. First of all, we had said it was most common site is the attached mucosa. Now it is happening on all over the mucous membrane of the mouth, in which both discrete and confluent lesions form rapidly in certain sites and feature round to oval crateriform base, raised reddened margins, and pain. They may appear as attacks of minor or single, major or multiple, or herpetiform lesions. They may or may not be associated with ulcerative lesions elsewhere. The cause of RAU, recurrent aphthous ulcer, is unknown. Local and systemic conditions and genetic, immunological, and infectious microbial factors have been identified as potential causes. The condition may be caused by a delayed hypersensitivity to the L form of Streptococcus sanguinus. But as we said before, it is unknown cause. It could be discrete or confluent lesions. Again, discrete or confluent, and could appear associated with other ulcerative lesions elsewhere. Treatment: the focus on promoting ulcer healing, reducing ulcer duration and patient pain, maintaining the patient's nutritional intake, and preventing or reducing the frequency of reoccurrence of the disease. A variety of treatment have been recommended for recurrent epiphyseal ulcer, but a completely successful therapy has not been found. Topical anti-inflammatory and analgesics, medications, and/or systemic immunomodulating and immunosuppressing agents have been used for recurrent epiphyseal ulcer. The primary line of treatment uses topical gels, creams, and ointments as anti-inflammatory agents. Now let's go to something as important of the acute gingival diseases is called acute necrotizing ulcerative Gingivarius. After we have talked about herpes simplex virus, acute gingival stomatitis, acute herpetic gingival stomatitis, and aphthous ulcers. This one is called Vincent's infection, ANUG. The infectious disease, commonly referred to as acute necrotizing ulcerative Gingivarius, rare, common in preschool children, occurs occasionally in children from 6 to 12 years old and is common in young adults. It can be easily distinguished because of the involvement of inner proximal papillae and the presence of pseudomembranous necrotic covering of the marginal tissue. Two microorganisms, Borrelia vincenti and fusiform bacilli, are the two microorganisms existing in this disease. They referred to as spirochetal organisms, and generally believed to be responsible for the disease. The clinical manifestations of the disease include inflamed, painful bleeding gingival tissue, inflamed, painful, and bleeding gingival tissue, poor appetite, fever as high as 40 Celsius, general malaise, and fetid odor. Fetid odor means bad odor. How to treat acute necrotizing ulcerative Gingivarius is when the disease is treated with subgingival curettage. It is dramatically responsible within 24 to 48 hours of the initiation of the disease. Debridement is also within this period of time, and the use of mild oxidizing solutions. If the gingival tissues are acutely and extensively inflamed when the patient is first seen, antibiotic therapy is indicated. Improved oral hygiene, the use of mild oxidizing mouth rinses after each meal and twice daily. Rinsing with chlorhexidine will aid in overcoming the infection. Another acute gingival disease is called acute candidiasis. Thrush, candidiasis, monilias, candida or monilia albicans is a common inhabitant of the oral cavity, but may multiply rapidly and cause pathogenic state when tissue resistance is lowered. Young children sometimes develop thrush after local antibiotic therapy, which allows the fungus to proliferate. The lesions of the oral disease appear as raised, furry, white patches, which can be removed easily to produce a bleeding underneath in the underlying surface. Treatment of such condition, acute candidiasis, with antifungal as usual. Antibiotics are available to control thrush. Another disease called acute bacterial infection that could also cause the acute gingival disease. This one is characterized by the acute streptococcal gingivitis, which is painful, vivid red gingivae that bleed easily. The papilla had an enlarged and gingival abscess had developed. The disease is difficult to make, however, without extensive laboratory tests. So it is difficult to diagnose without extensive laboratory tests. The treatment of such disease is with broad-spectrum antibiotics if the infection is believed to be bacterial origin, and improved oral hygiene is important in treating the infection. As with any other acute microbial oral infection, chlorhexidine mouth rinses are also appropriate. Now, after we talked about the diseases that cause the gingivitis or acute gingivitis, now let's talk about something else. This one is called the chronic non-specific gingivitis. Again, chronic non-specific gingivitis is a type of gingivitis commonly seen during the pre-teenage and teenage years. The chronic gingival inflammation may be localized to the anterior region or may be more generalized. Although the condition is rarely painful, it may persist for long periods without much improvement, characterized by a fiery red gingival lesion, and is not accompanied by enlarged interlabial papillae or closely associated with local irritants. The cause of gingivitis is complex and is considered to be based on multiple of local and systemic factors. First of these factors is dietary inadequacies are often found in the pre-teenage and teenage groups. Insufficient quantities of fruit and vegetables in the diet, leading to the subclinical vitamin deficiency, may be an important predisposing factor for an improved dietary intake of vitamin, and the use of multiple vitamin supplements will improve the gingival condition in many children. Next factor is malocclusion, which prevents adequate function and crowded teeth, which make oral hygiene and plaque removal more difficult, are also associated and important predisposing factor in gingivitis or chronic non-specific gingivitis. Another cause is carious lesion with irritating sharp margins, as well as faulty restorations with overhangs margins, both of which cause food accumulation, also favor the development of the chronic type of gingivitis, as we are talking about chronic non-specific gingivitis. The irritant, another factor, the irritant to the gingival tissue produced by mouth breathing is often responsible for the development of the chronic hyperplastic form of Gingivarius, particularly in the maxillary arch. This is mouth breathing in the maxillary arch, very irritant to the gingival tissue. All these factors should be considered contributory to chronic non-specific gingivitis and should be corrected in the treatment of the condition. After we have finished the diseases that were causing an acute inflammation, which specifically acute gingival inflammation, now let's talk about the gingival diseases that are modified by systemic factors, one of which is gingival diseases associated with the endocrine system, or even better called puberty gingivitis. Not gingival disease associated with endocrine system. Endocrine system can be replaced with puberty system gingivitis, and this one is a distinctive type of gingivitis that occasionally develops in children in the pre-puberty and the puberty period. The gingival enlargement was marginal in distribution, and in the presence of local irritants was characterized by prominent bulbous inner proximal papillae, or far larger than gingival enlargement associated with local factors. The enlargement of the gingival tissues in pubertal gingivitis is confined to the anterior segment and may be present in only one arch, even in the mandible or the maxilla. The lingual gingival tissue, originally remains unattached. So we have the lingual gingiva and the buccal or labial gingiva. Lingual gingiva is unattached in the pubertal Gingivarius, or it is called the endocrine system Gingivarius. The treatment of such disease should be directly toward improved oral hygiene, removal of all local irritants, restoration of carious teeth, and dietary changes necessary to ensure an adequate nutritional status. This disease, in severe cases of this disease, pubertal or endocrine system gingival enlargement, in severe cases of hyperplastic gingivitis that do not respond to local or systemic therapy, should be treated by gingivoplasty, surgical removal of the thickened fibrotic margin, and in a proximal tissue has been found effective. Reoccurrence of any hyperplastic tissue will be minimal if adequate oral hygiene is maintained. One of the diseases that affect the gingiva that is a systemic disease is gingival lesions of heredity origin. This one is very familiar and very important disease that affects the gingiva, called hereditary gingival fibromatosis, HGF, heredity gingival fibromatosis. That's characterized by slow progressive benign enlargement of the gingival region. Genetic and pharmacological induced forms of gingival enlargement are known. The most common genetic form of hereditary gingival fibromatosis usually has an autosomal dominant mode of inheritance. The gingival tissue appear normal at birth, but begin to enlarge with the eruption of the primary teeth. Although mild cases are observed, the gingival tissue usually continue to enlarge with eruption of the permanent teeth until the tissues essentially cover the clinical crown of the teeth. The dense fibrous tissue often causes displacement of the teeth and malocclusion. The condition is not painful until the tissue enlarges to the extent that it partially covers the occlusal surface of the molars and becomes traumatized during mastication. To treat this disease, surgical removal of the hyperplastic tissue is achieved, and a more favorable oral and facial appearance is also achieved. However, hyperplasia can reoccur within a few months after the surgical procedure and can return to the original condition within few years. The importance of excellent plaque control should be stressed to the patient because this delays the reoccurrence of the gingival overgrowth in the gingival heredity or the heredity gingival fibromatosis. Another systemic factor that affects the gingiva is the Phenotoid-Induced gingival overgrowth. And this one, PIGO or dilantine, dilantine is a major anticonvulsant agent used in treatment of epilepsy, varying degrees of gingival hyperplasia. One of the most common side effects of the phenytoin therapy. So one of the most common side effects of phenytoin dilantine is the induced gingival overgrowth or hyperplasia with varying degrees of that overgrowth. Treatment is surgical removal as usual of severely overgrown tissue in phenytoin-induced gingival overgrowth, PIGO, and good oral hygiene after surgery are generally considered to be the most effective treatment. However, even these procedures have often been followed by a gradual recurrence of the fibrous tissue. Using of a series of pressure appliances may help reduce the size of the gingival overgrowth without surgery. Ascorbic acid deficiency Gingivarius. This is another systemic factor affecting the gingiva and is associated with vitamin C deficiency and differs from the type of gingivitis related to the poor oral hygiene. This involvement is usually limited to the marginal tissues and papillae. The child with scorbutic gingivitis may complain of severe pain and spontaneous hemorrhage will be evident. Severe clinical sclerobutic gingivitis is rare in children. However, it may occur in children allergic to fruit juices when provision of an adequate dietary supplement of vitamin C is neglected. The treatment of vitamin C deficiency will be daily administration of 250 to 500 milligrams of ascorbic acid, vitamin C. In older children and in adults, they may require 1 gram of vitamin C for 2 weeks to respond and recover dramatically. Thank you for listening to this lecture. We talked about how to treat the gingivitis and periodontal diseases associated with children, and we talked about many diseases of the periodontium, the gingiva affecting children, including gingival enlargement and gingival inflammation.